So now I'd like to welcome our panel. If they could come on camera, that would be really helpful, and perhaps others could go off camera just so you're looking at the panel. I think we've got everybody. We just need Barry, perhaps. So for many of you, you'll know that over the last, since the inception of the Regional Scale Programme and the Innovation Collaborative, you've been working on virtual wards. So some of the people on this call, what you're going to hear discussed now, because we've moved from what was local initiatives to regional scale to now what is a national initiative. And you've contributed to that. So we've got a really great panel, and I'm going to ask them, I'm going to go to them in turn and ask them to introduce themselves and give you some insight into what they're doing in this space at the moment. I'm going to go first to Steph because she can give us the big picture from a national perspective. Steph, over to you. If you'd introduce yourself and just say a little bit about what your role.
Thanks very much, Breid. It is really fabulous to be here today, and what a fantastic audience. I'm really excited to get into a discussion about virtual wards. So I just look like I froze there, but I think I'm okay. So yeah, really, we've got a new national programme on virtual wards, but it very much builds on the work of the regional scale programme over the last year and brings together work to develop virtual ward pathways in NHSEI with the tech based development of virtual wards and remote monitoring that we've seen over the last year. And our objective with this national programme is to support systems to scale and spread virtual wards. And as Tim said earlier, really to measure and evaluate impact so we can build and extend that model. And as Tim said, that's really important given the amount of funding that we have. That's £500 million over 2 years to sort of really transform the way that we deliver acute care, essentially. And ultimately, our objective is to provide care closer to home with the equivalent, if not better, outcomes for patients that Tim alluded to. But also, it's vital for recovery, right? We see this as a critical way to extend acute capacity, but it has to be in that safe and sustainable way. Just wanted to say that this programme is not about the very fast rollout of COVID virtual wards that we've seen over the winter. This is a 2-year programme that should build on existing services and integrate with them. And, you know, we know that there's some amazing pioneering work on virtual wards happening across the country. So this is about supporting scale and spread, but the ambition is significant. In the operating guidance published in December, we're working to a national ambition of 40 to 50 virtual ward beds per 100,000 of the population. So that's scaling of the order of 3 to 5 times where we are now, depending on where you are. So it's a significant transformation in the way we deliver acute care. And just before I hand back to Breid, you know, that definition is really important. We are with virtual wards talking about the replication of acute hospital bed capacity at home. We're not talking about long-term management conditions of home, and that's really important to get the benefits of extending capacity. And we're also supporting 2 distinct types of virtual wards as well. So through the regional scale programme, we've been supporting the tech-enabled virtual wards with which are fundamentally there's remote monitoring, consultant oversight, but perhaps little face-to-face care at home. But with this programme, we're also supporting hospital at home type models for patients with more complex conditions such as frailty, where you see a blended approach of face-to-face support at home, IV therapies, etc., care assessments at home with digital. So our programme supports both those models, and as a minimum, we're asking systems to implement, you know, 2 kind of key user cases for acute respiratory infections and frailty, where we see huge benefits for a significant cohort of patients. But, you know, this is just the beginning, and we really want to work with systems on their pioneering work to introduce new pathways, and we'll be seeking your help to kind of develop and scale those models. So thanks very much for letting me kick off. I'm really looking forward to hearing from the others about actually how you do this on the ground.
Thanks, Steph. And it's suffice to say there's a lot of support being put into this, isn't there, from a national recognising the importance. Barry, I'm particularly delighted to be able to welcome you today. Do you want to just take a few moments to tell us about what being a patient on a virtual ward meant to you, and what you would like the people trying to do this to hear?
Yeah, good morning, everyone. My experience on the virtual ward was I'd got support from my nurse, healthcare nurse. My family was very sort of confident that if anything happened to me, they knew that they could contact her or them, because I had two, and it gave us very, very good, like I say, confidence in knowing that everything was going to be okay when I came out of hospital, because I spent a month in hospital, and you're in hospital, and you all you have to do is sit there and eat your meals and take your tablets. When you come home, I felt it was a sort of being pushed out the door, and that was it, sort of thing. But when I started on the telehealth program, it was brilliant, absolutely fantastic for me.
And thank you, Barry. And you know, some people worry about leaving hospital and maybe the safety they feel in hospital. How did that feel to you? Was it different?
It was the same. When I left hospital, as I say, all you have to do in hospital is eat your meals and take your medication. When you come home, I had a raft of medication to take every day, and it was, to be fair, it was a shock. It was a real shock for me. But I knew that I'd got the heart specialist nurse, who I could contact, and to be fair, I contacted her more than my GP. If I had an issue, I would ring them, and they would they would ring me. I remember one Saturday, I was sitting in the conservatory reading the paper Saturday afternoon, and the heart nurse rang me. She said, one of your data that you put in was quite high. How are you feeling? And I said, fantastic, you know. So it's very reassuring.
Thanks, Barry. That's really good to hear, and I know that we'll come back to for some questions later. I'm going to now go to Vin, and Vin, if you can introduce yourself, but giving us a regional perspective on what this means and the opportunities and challenges.
Thanks, Breid. So I'm Vin Diwaker. I'm the Regional Medical Director for London, but I'm also a consultant paediatrician by background. So if I'll just start really by making 3 points. So one is, about 10 years ago, I had to have a period of leave. And when I came back, my colleagues had got together and they'd set up a virtual ward for acute general paediatric patients. And my reflection of them working in that system was, honestly, when you went round and spoke to parents and children and young people, and you said to them, you can go home, but the clinical team will come out, they'll see you, they'll take their observations and they'll feed back. And the consultant's still in charge, so we'll do this as a ward round every day, but virtually. They would sit there and they'd say, can you really do that, doctor? And so absolutely, the patient experience, even 10 years ago, before a lot of the technology was available, the human element of doing this was still, which shows you the potential that we've got building on a really strong historical base. The second piece just to reflect on, of course, is that it's not just that your best, the best bed is your own bed. It's not in a hospital bed. Over 65% of patients in hospital beds in the country are over 65. And for every 10 days that someone over 80 spends in a hospital bed, they lose 10% of their body weight. 10% of their body weight in just 10 days. So I think what we're doing here today, and as part of this programme and what Steph's doing and what we're getting to, there's a moral purpose behind it. There's an economic case and there's a technical case for it. There's a clinical outcomes case, but it's a moral case as well. So that would be the first point I'd make. That's what really motivates me. So the second bit in London is we currently have about 400 virtual ward beds, which isn't anywhere near the national ambition. But there's a huge degree of clinical enthusiasm for the programme, and they're confident that we can get there. But only about half of those beds have actually got patients in. And my reflection as a clinician is that firstly, there was a kind of workforce element to this that my team report back that we know in London and that I experienced myself. So we need not just enough workforce, but we need to have their skills. We need accurate clinical pathways. They need to be backed up by feedback, data, evidence. And if I'm absolutely honest, the biggest barrier I'm often quoted is clinical confidence in the virtual ward. It took me about 3 months before I felt really confident, and then I was its biggest advocate. So we've got to work through that human element, the clinical governance elements as well. And then the final point, Breid, if I could just make, this is about the technical component of this. So there are over 20 different products now in virtual wards in London. So London's got 9 million people. We've got 5 integrated care systems. There's at least 4 to 5 products currently used in different London systems. Of those, only 5 of them are interoperable with current clinical systems. That's in primary care and in secondary care. Now, of course, as Tim mentioned, as a clinician, I want all the information to be available at the point of care. In London, we have a fully integrated care record at the point of care that integrates health data across primary and secondary care, and increasingly is bringing in social care data. But a lot of the data that we're collecting from the virtual ward isn't easy to load into the systems. It's possible, but it's complex. And so I think over the next few years, we're going to have to agree on a platform strategy. We're going to have to have a strategy for consolidation. But I think we also need to be clear that doesn't mean we're going to lose space for innovation. This is a fast moving sector, particularly technically, and we do need a methodology for allowing innovation and change as well. So thanks, Breid, and thank you for inviting me. It's great to hear your story, Barry. Thank you.
Thank you.
Thank you. Thank you. And last but definitely not least, we're going to Bushra, who's going to tell us about the Greater Manchester experience and what you're doing.
Thank you, Breid, and thank you, everybody. So my name is Bushra Alam. I'm an acute physician at Salford Royal. I also lead the Greater Manchester COVID oximetry at home, COVID virtual wards, and our new programme, which I'm really excited about, which is our virtual hospital across Greater Manchester. So we're an established ICS, and we came together as an ICS to set up the oximetry at home and the COVID virtual ward programme. And we have a really good programme across our ICS. We meet regularly on a weekly or a fortnightly basis to discuss how we implement the oximetry at home and the COVID virtual ward, and now our new programme, which is the Greater Manchester Hospital. That collaborative approach that we've had has enabled us to create a safe space where people can come together, clinicians, operational managers, anyone delivering virtual care can come together into that safe space and be able to share and learn from each other. And we found that sharing and that learning together from each other has really helped us to establish our pathways at great pace. We've been able to share challenges, and we're able to problem solve together as well. So at the moment, we've got our current health bid, which has enabled us to buy 400 virtual care beds across our ICS. So each locality, there's 10 localities in Greater Manchester, will have 40 virtual care beds. And these virtual care beds are to enable us to discharge patients from hospital earlier in their clinical trajectory. So patients who may otherwise have stayed in hospital for a further 1 or 2 days whilst they step down from IV antibiotics to oral, or whilst the clinicians monitored an improvement in their clinical symptoms, these patients hopefully will be able to go home with this enhanced remote monitoring that we have. And we're in the process of setting that up. What we hope is our virtual care beds that we have in each locality, we want to link them into our existing community resources. So our community diagnostic hubs, which we've set up, should be able to help facilitate any patient who might require blood tests. And we also hope to link into existing community services, community nurses and hospital at home programs that we have. So we're really excited about this new project, and we really feel that this project will enable us to free up hospital capacity, to empower patients like James to feel more comfortable, Barry, to feel more comfortable at home, to be in their own environment while still receiving care, and also to empower our clinicians to be able to discharge patients more safely back home earlier in their clinical trajectory and free up much needed capacity. We don't know what's around the corner. We don't know when the next wave is going to come. We don't know what this winter is going to bring. So we've really accelerated and mobilised that pace to develop this as quickly as we can, getting ourselves ready for what comes next, unfortunately, in this pandemic.
Thanks, Bushra. It's great to hear the different views at different levels in the system and from a patient perspective, and lots of questions in the chat that we're not going to get through all of, but we will make a commitment to answer questions offline. And I'm going to go through a couple of questions and give you forewarning. Vin, there's a question for you about what gave you the confidence after 3 months, so we can come back to that. Bushra, for you, I know you've done some work on inequalities, and there's a question about digital poverty, but maybe how you're dealing to ensure nobody's negatively impacted. That might be helpful if you could perhaps comment on that. And for you, Steph, there's a question about workforce. Where's the workforce coming from? And I know you've been doing lots of thinking on that, so perhaps we can come to that. But Barry, just is there anything you'd like to comment on what you've heard from the other 3 people on the panel?
Yeah, for me, it gave me and my family confidence to know that when I left hospital, which was a massive shock for me, a month in hospital, to know that I could contact somebody and they would sort everything out for me, or if my medication wanted altering, I knew that they would sort it out for me. They would contact the consultant, and now I've got the confidence to self-medicate with my diuretics. My diuretics give me gout, so now I can alter my diuretics, to suit my sort of situation, really, which I wouldn't have done in the past. And the other major thing for me is I haven't got to ring the doctor, make an appointment, go down to the doctors. I know that, or I knew that I could just contact my heart nurse and she would sort it out for me, which was
great. That's a perfect segue to Vin then. So we've Barry's told us what made him confident. Vin, what made you confident on the other side as a clinician? Oh, you're on mute.
Yeah, sorry. So I'll tell you a brief story. So when I was a registrar in the mid-1990s, so way before virtual wards, we once had a patient who was very needy who went home for monitoring at home and for administration actually at that time of antibiotics at home. And that child died at home. And then, of course, after that, everyone was very scared. So I was brought up as a registrar from the mid-1990s saying, never send anybody home until you're absolutely certain that you were safe. And then if you then reflect on, I don't know what Bushra finds, but a lot of us who worked in hospitals very rarely go and work in community-based settings. And so our attitude to risk is very different. So often if you talk to GPs or consultants who work in the community or nurses who work in the community, physios, they say your attitude to risk in the hospitals is so much lower than ours. You won't send anybody home. So I think being aware and spending some time working in out of hospital settings certainly helped me. The third bit was, of course, we had really good clinical governance. So unlike the mid-90s example where it was the first time we'd ever done it, we'd really thought about this. We'd thought about the workforce. We thought about the pathways. We had an audit system in place. And I still went round and did a ward round on the virtual ward patients every day. So I knew who those patients were and was getting real-time feedback. And then the final thing was clinical pressure. So when I first came back from leave and stopped sending, I wasn't sending patients home that my colleagues were. They went, you could have sent that patient home, Vin, why didn't you? So I had a feedback loop, but also there was sort of peer pressure, if you like, to actually go ahead and do it. And then, so after about 3 months, I just realised how great it was, both from the patient's perspective. I think the final thing I'll just say that's been again something to do with that moral purpose I thought of at the beginning is if you're a carer, my daughter's a carer, and she has to take time off work to care for a relative or someone who's in hospital. A, she doesn't get paid, and B, She has to get the bus to come into the hospital and spend most of her day. So we really shouldn't affect not just the impact on patients, but also the huge impact that it's got on their families and real hardship if we don't go ahead and do this.
Great, thank you. And I realise I'm not chairing terribly well because we are running out a little bit, but I'm going to go to Steph and Bushra for the 2 questions. We're prompted, and we will pick up other questions and respond in chat. Don't know who wants to go first. Steph, do you want to go first on the workforce?
Yeah, so I think we're seeing system staff virtual wards in different ways. So we have community-based models where we're seeing staff drawn from some crisis response teams and frailty clinics and district nursing to really look at that cohort of patients who could be looked after in the community rather than in hospital. So it's a reconfiguration of existing teams plus recruitment of some new staff. Granted, recruitment is extremely tight at the moment. And then seeing some really innovative models on sort of the more acute led side with staff being who are closer to retirement, who don't want to do sort of ward-based work anymore, leading some of this digital work, using some of the consultant support has been described to cover those individuals on virtual wards as well. So a mixed model of new recruits, redeploying staff who might have otherwise retired and using existing staff. So and we're going to be publishing guidance as well to give some indication about how you can staff and what kind of staff you need to support virtual wards as well, coming out at the end of February to help systems start to put together the picture. Thanks.
Yeah, it's a lot of focus on workforce, isn't there? Great, thanks. And Bushra, just the inequality question, and there was also another question appeared in the chat about when people don't have devices, etc. So if you could pick those.
So in terms of inequality, I think Greater Manchester is a very diverse area and an area of considerable poverty. So for us, it was really important to make sure that everybody could be included on our pathways. So if I give the example of an oximetry at home pathway, I remember a colleague of mine saying to a patient who'd come saying to me, this patient's come into ESTEC with a pulse oximeter. I don't know why he's got a pulse oximeter. He can't speak a word of English. And it was his daughter that was inputting the patient's saturations and helping the patient to be able to use technology. So we really do need to think quite laterally and quite widely about how we use our technology and who can be available to help the patient. Patient may not be able to speak English, but there may be family members or carers who can support the patient to be able to use the technology. And this patient was then able to benefit from having the same technology in his home that that everybody else was having. So access to technology and being able to think more widely is really important. And I think also thinking about what technology we use. So currently our new technology uses Bluetooth devices and a patient portal where we can speak to the patient or speak to the carer. And I think that's going to be really helpful in ensuring that we have more patients that are being able to enroll on our system. So the Bluetooth will enable easier connectivity and the patient portal will enable face-to-face conversation with the patient or the carer. So I think we've worked really hard also within the Oximetry at Home programme to make sure that groups of patients, for example, patients that are in mental health hospitals as inpatients, also have access to pulse oximetry. We worked with prisons to make sure they also have access to pulse oximetry. And we worked with in care institutions, eating disorders and care homes to make sure they also had access to pulse oximetry. So I think it's really important to not just think about patients in community or patients that were discharging home, but patients in other inpatient settings that will benefit from having access to care and ensuring they also have equitable access to digital technology going forward.
Great, thank you. There are so many questions in the chat, so I don't know if our panel members have time to just have a look and feel they can respond. That would be brilliant, because unfortunately we've run out of time. But thank you to everybody. Lots of really useful insights. It feels like it's the start of a conversation, but as we know, this is a 2-year programme, so I'm sure we will have many more conversations. And there's lots of questions in the chat about interoperability, and I can say it's top of our agenda. So it's heard loud and clearly from Tim's point and Vin's point about, things flowing and being easy for clinicians. So we've heard that loud and clear, and it's definitely a focus. But thank you very much, and thank you, Barry, for joining us. and we please do stay with us if you can.